Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. And today we are doing an STS AABIP crossover event. I'm one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. My co-hosts, Hari, Jeff, Dane, and I are so excited to bring you the latest and greatest in thoracic surgery. I'm so delighted to be joining you today with a dear friend and colleague, Samir. We're doing a crossover event. We're so excited. It's STS AABIP Airway Series. We were lucky enough to spend some time together at Vanderbilt, often tackling very complex airway cases together. And so I'm so excited to be chatting with you today, kicking off our three-part series. Samir, how fun is it that we get to hang out today together?
Erin, we've been planning this for months, and I'm so pumped that we can finally kick this off. And to all of our listeners, welcome to a very special episode of the AABIP podcast. I'm Samir Avasarala from Case Western Reserve University School of Medicine in Cleveland, Ohio. As Erin mentioned, this episode marks the launch of a brand new collaboration between AABIP and STS. Together, we'll really be diving into topics that matter deeply for both of our communities, starting with one that fits right at the intersection of our fields.
Absolutely. And you guys, we're not coming alone. So a special welcome to Britney Scott. Britney Scott is an extraordinary ENT surgeon who I've had the privilege of working with at Creighton University Medical Center. And together we actually helped to build an airway program managing both malignant and benign diseases. Britney, welcome.
Hi, guys. Excited to be here. Just a little bit about myself. As Erin said, I am one of the head and neck surgeons. I do head and neck oncology here at Creighton University, and I've had the pleasure of working together with her on multiple cases that have been quite interesting and fun.
Now, Samir, you had the brilliant idea of doing a stepwise approach for the location of the tumor and malignant disease. So, my friend, take us through our anatomic journey today.
One thing I think all three of us can agree on is major airway disease. It's incredibly complex. Today, we're really going to zero in on malignant disease and walking through it from top to bottom. The other thing we can agree on is absolutely there's no one-size-fits-all approach. Britney, I'd like to pick your brain first. When you think about a real multidisciplinary approach to these cases, what does that look like in your practice? And what resources really need to be in place to make sure the patients get the level of care that they deserve?
Yeah, good question. So as you know, we're mainly talking about malignancy here, and at anybody who delves, into the world of cancer, they know that multidisciplinary care is the mainstay of treatment. So with that, with cancer especially, you're working with radiation oncology, medical oncology, speech therapy, and then when we're getting into airway stuff, you're really talking about swallow therapy, speech therapy, and then the thoracic surgery, interventional pulmonary team. I mean, the list could go on and on as you start getting into complex surgeries as well, including like anesthesia teams. So that's kind of the mainstay when you're talking about the complex care teams there.
Mm-hmm.
I love that. So, Samir, you mentioned a little bit about location tumor, which so critical, but let's face it, a lot of decision making beyond being surrounding sort of the location of the tumor, it's also where it started. So is this a purely endoluminal? Is it dominantly extraluminal with compression, or is it sort of mixed? And obviously the source of it also has a big impact on treatment. Britney, in the neck, obviously there's a lot of cancers that can impact the airway, including obviously squamous is a dominant disease that you deal with, thyroid pathologies, parathyroid pathologies, all of which can have sort of different implications. We're not going to spend quite as much time on extrinsic things that are invading the airway, but let's start just a little bit and touch on that just a little bit, because I do think it's important. So for extrinsic tumors, Brittany, what are some of the tools in your toolkit for approaching these when you're thinking about a patient that maybe has a very large tumor that's compressing the airway directly or maybe invading a portion of it?
Yeah. So the big thing for me, and this is a good question, because when you think of head and neck cancer, a lot of majority of airway things, people are thinking, oh, like voice box cancer, laryngeal cancer, and you kind of have your answer intuitively of what's going on there. The less frequently you see like extrinsic tumors coming in. So the big thyroid pathologies, anaplastics, some poorly differentiated thyroid cancers can really cause you some, um, you know, pretty drastic changes to the airway. And when you look inside, it actually, you're like, oh, this isn't as, as doesn't look as bad as it is. For me, the big thing is, how am I going to secure the airway for safety? Because when it starts becoming an intrinsic pressure, you're thinking, well, how do I get a safe airway to get them to a treatment? Whether that be, induction therapy, surgery. And so those are kind of my big things from an extrinsic standpoint, because there's not a lot you can do quickly if the airway is being compressed and the whole neck is involved from an extrinsic tumor. And so that's kind of my big thing. And the toolkit I use are essentially just a great anesthesia, interventional pulmonary team, thoracic team to consider. Do we need a temporary stent? Getting radiation oncology, medical oncology, somebody involved to help kind of expedite treatment care.
I love that. And actually, I think it's a perfect opportunity to have Samir comment, because you are sort of one of the experts in stents, which sometimes really serves such a critical tool in this time period.
Yeah, absolutely. So with extrinsic compression, I like to see IP as very useful, and then in some instances, not as useful. Let me explain that a little bit. So I look at extrinsic compression as compression. The simple question is, what's crushing the pipe? The pipe being the trachea or any other airway. And in reality, my bronchoscopic tools can do nothing about that primary process. I can't make that thing, whatever is crushing it, whether it's a lymph node, thyroid, et cetera, shrink. So really what I can do is establish the luminance of the airway, and generally that's via a stent. Now, stenting really is going to matter where it's going to be, et cetera. Some stents are more high risk than others, but they're often the only way that can immediately restore patency so the patient can move on to what's next, whether that's chemo, radiation, immunotherapy, surgery, or a combination of those things to help treat that compressive mass.
Love that. I love that. Okay, guys, last thing before we jump into anatomy, because I sort of want to talk about some of these hard and fast rules, break down some of the myths that we hear a lot about in training and in applications to practice. So when I was in my training, and I swear this is in textbooks, I heard this in the operating room, there was this hard and fast rule that it all came down to the exact size and diameter of the airway obstruction, right? So if you were doing something with exertion and you're under 8 millimeters, you're going to be horrifically symptomatic. At rest, 5 millimeters. So essentially the airway had to be pretty massively obstructed before people could tell if there was a problem. And while I do acknowledge that Poiseuille's law factors in radius to the fourth power, right? So radius plays a huge, huge part of this. The formula also incorporates length, right? So it's 8 times the length. And we don't really talk about that a lot, nor do we talk about the patient factors, right? So the physical ability for the patient to generate breath. And I sort of think about frailty. So you guys, talk to me a little bit about your experiences. Do you use these hard and fast rules, or are you really just saying, hey, a different amount of obstruction is going to impact every patient differentially. And sometimes we have to be more aggressive, even when it's less, because of the patient scenario. Samir, I'll throw to you first this time, and then Brittany, let's get your thoughts too.
Erin, you bring up great points. And first off, thank you for pronouncing the law, because I still can't get that name right. And it's been several years. So I think it's always helpful to have some sort of starting framework to help guide decision making. However, in my experience, those numbers and equations may not really hold up in patients in the real life setting, because a lot of the folks that we work on don't have normal lungs and don't have other parameters of normal cardiopulmonary physiology. As we all know, that's not the reality for most of our patients. So even though those numbers are good starting points, when it comes down to these underlying derangements, even a small degree of airway compromise can translate clinically into meaningful consequences, often not in the good sense.
Brittany, what are your thoughts?
I agree. I think too, when you take patient factors into account that are not in a scientific equation. Like you hit the frailty, patient's ability to breathe, their lung status. I mean, when you read every ENT textbooks, they're like unified airway, starts from the top all the way to the lungs. And it really truly is. So you have to take everything into account to see, hey, it's not just this one small area. It's really how the whole mechanism works together. And there can be multiple things that play into, affect a patient's breathings and symptoms that aren't just the size of their airway.
Mm-hmm.
Love that. Absolutely. Okay, you guys, let's get into talking procedures because obviously that's our favorite thing as surgeons and as proceduralists. So you guys, first patients coming in, we've got a lot of dyspnea, concern for airway obstruction. Let's talk about sort of the standard workup that we want for a patient presenting with concern for some kind of an airway lesion, airway mass, airway obstruction. Patients in your clinic, we've got Stryder. Talk me through what are the first orders, first steps? What are you guys thinking as far as workup for this patient? Brittany, let's start off with you, and then Samir, talk me through your protocol too.
Mm-hmm.
Yeah, no. So Stryder, and they're just how they walk and present themselves into the room can tell you a lot. You can really tell somebody's symptoms, how hard it is for them to get up, walk to the chair. If you can really hear their Stryder, I'm kind of immediately going to my clinical exam. I take their history, smoking history, everything from a cancer standpoint. And then eventually I do a scope in office. I do a flexible laryngoscopy, and that's essentially just through the nose down to the airway and to take a look at the whole upper airway. This can tell me if there's a pharyngeal mass, a supraglottic lesion, a glottic lesion. I can get a brief, good view of the subglottis if it's safe. Sometimes you can do local anesthesia through the airway during, like anterior through the trachea during the clinic exam. So that way you can get a little deeper if you need to. But that's kind of my go-to in the clinic. And then if I obviously see something, I'll, progress from a cancer standpoint, progress kind of down that pathway about clinical imaging, biopsy, things like that. If their upper airway is, relatively clear, so their vocal cords are moving, I don't see any masses, they sound horrendous, but clinically their flexible laryngoscopy looks okay. That's kind of when I start to turn to you guys, your other teams, my other teams, interventional pulmonary, pulmonology, thoracic surgery, to start doing a little bit more investigation on kind of the airway, starting with probably CT imaging and then a call to one of you.
I love that. And it's not uncommon that you and I actually end up in the operating room together, scoping people together. So we figure out exactly what the culprit is and figure out how we can tackle it together, right? Which is amazing. Samir, how about you?
Yeah. So, the old saying, a picture's worth 1,000 words. In this situation, pictures are important, but seeing and listening to the patient is also worth 10,000 words. So to build upon what Brittany was talking about, really how they're dealing with their functional status, walking around. How bad is that Stryder? Can they lie flat? Can they not lie flat? Can they open their mouth that I can get a rigid bronchoscope in them without too much trouble? In addition to that, I will take the help of any CT imaging that I have. If this is a patient who's had bronchoscopies before, a thorough review of their previous bronchoscopy reports, whether it was done at our institution, a different institution, can be very helpful. Any reports from nasopharyngoscopy that our colleagues from ENT have performed, whether it's in office or in the hospital, any standard blood work that I can use to go to the OR or the endoscopy suite. And one thing that I always try to look into is some objective data on cardiac function. The reason for that is, one, can they tolerate general anesthesia safely? Two, what if their shortness of breath isn't necessarily being driven by everything going on here or down here, and their PA pressures are 52 or something like that? I think that raises red flags for different issues, but holistically, it can affect the patient the same way with their dyspnea.
Oh, 100%. And let's face it, a lot of people have concomitant problems that are all contributing to the same symptomatology. And so, don't always hang your hat on one thing, right?
Mm-hmm.
Amazing. All right, Samir, kick us off. Take us down the airway.
All right, so let's start from the top. Approaching malignant airway central obstruction. We'll talk about the subglottics and the upper trachea. So this is an area that patients can present with dramatic symptoms. We've seen this they're very dyspneic. They could be coughing up blood, and the CT scan may show something very ugly up in that area, whether it's a CT neck, dedicated CT neck, or a CT chest. And this causes a good amount of anxiety amongst the teams about managing this thing. Let's imagine this patient had a large endoluminal tumor just below the cords, areas that all of us have some degree of expertise managing. But Britney, I'd love to hear about your endoluminal approaches for something this high up, and
Sure.
I'd supplement with what I would think we would do from the IP perspective.
Yeah, no, for sure. So it's funny because this is the top of your field. This starts to get to the bottom of my field. We're like right at the cutoff. But so primary subglottic cancer. So when you think of like laryngeal cancer, supraglottis, glottis, very common smoker, squamous cell carcinoma. A primary subglottic tumor, less common from a squamous cell standpoint, but you can get some other very interesting cancers that kind of primarily present in this area. So my spidey senses and my curiosity goes a little bit up, because this area is a little bit separate from what you primarily see from like a primary head and neck supraglottic glottic cancer. Sometimes, majority of the time, what you're going to see is that they have a very submucosal glottic mass, and that it is extending into the subglottis. And you just can't quite appreciate the tip of the iceberg that's in the glottic airway. And then what you're seeing is where it's kind of expanded down, and now it's transglottic, and now that's where you're seeing the big majority of the problem. And so my first things, again, always with airway is safety. How are we going to secure an airway? And then you're kind of always thinking, well, what are going to be the options for treatment? How do we secure an airway? And if surgery's in that picture, how we do that where we're giving us the kind of down the line, the best surgical outcomes from like a resection standpoint, things like that. So endoluminally, if this is cancer, you obviously are going to want to do a biopsy, but you're not really, if it's invading cartilage, there's not a lot of endoluminal things you're going to offer. At that point, when cartilage is involved, you're really talking about a full resection. There's just too many nooks and crannies where endoluminally, if you're trying to laser things out, you can, but you're also, this area is so tricky because you're dealing with one cancer. And I always tell patients this, you can resect anything. You can really take out a lot of things, but it's functionally what you're trying to save. If they can't breathe and they can't speak, then doing a big surgery for them doesn't change their life all that much. But if they're coming in here and they're swallowing just fine and their voice is okay, but not, that you can still hear them speak, then you're really starting to think, well, is surgery the right answer for them, or do we have other options for them? So I would say from a surgical standpoint, when you're having that big of an endoluminal tumor with cartilage erosion, things like that, you're really going to be prepping more from a surgical kind of perspective standpoint.
Good to hear. So the IP angle for us approaching this, really it's airway stabilization, but we don't want to compromise future surgery. So if time permits and the clinical status permits, I always engage my colleagues, whether it's thoracic surgeon, ENT, laryngology, about can we seek a surgical opinion option first? Sometimes that's doable, sometimes it's not. And if it's not, even though this area is fairly high risk for us, it's one of the largest tubes that we get to access. The trachea is very forgiving to some degree with a rigid bronchoscope, and it's not those smaller main bronchi, bronchosynovitis things. So if there's a large obstruction there, and this needs to be taken care of right away, from the endoluminal standpoint, if I'm able to, what I would do is just rigid intubate these folks, try to core out whatever I can, stabilize that airway, that tissue that comes out, send it for path, and then decide, hey, is stenting needed or not? I take that decision very seriously because higher trachea, not the best places for stents. They have a susceptibility to migrate. Distal, not so bad, but if they go up, it's going to be a big problem. And I just want to underscore that I would only approach this if a surgical option is not considered upfront. And once I'm going down there, one thing that I do is take a lot of pictures, take a lot of videos, invite my colleagues into the room if they're able to see what we're dealing with, because eventually one of us is going to have to go back into that airway again or see this patient in clinic to talk about more definitive options. Erin, how often are you getting called into these higher airway cases?
You know what? Not a huge amount, other than often when it is airway stabilization, right? I mean, it's sort of one of those situations where all hands on deck is always better. And the more people who have the more tools in their toolkit, especially when a patient is an extremis, is unbelievably helpful. But I'll tell you, a lot of the things that I think about for the more middle and distal airways as well, I think about for this too. And so if you are doing some coring or a little bit of lasering or a little bit of cryo or whatever it is that you're doing to try to stabilize the airway enough to get it open, thinking about having whoever's there for definitive resection is so critical, or finding a way to mark the airway, photograph the airway, measure the airway, so that when we head to definitive resection, we have a true idea of the extent of disease, to make sure that we're planning everything appropriately. The other thing that I think is always really interesting too is, and we don't think about this tool, I think often enough, we don't talk to our residents about it often enough, is the mediastinoscope. It is a brilliant tool. And sometimes when you have to do these very large, high resections and you really need to pull that trachea up a long distance, the mediastinoscope is a great tool to help free things up. So you have all the benefits of, your neck flex, freeing up that front part of the trachea to be able to pull things up higher. And so that actually is one of the ways that I end up getting involved in these cases as well for the definitive resections. And so, getting to hang out with colleagues in the OR is always fun. And getting to pull out my mediastinoscope because I don't get to sample lymph nodes anymore since you've stolen them all, Samir. It's not getting off the shelf.
There's something if I could add to, when we think about airway security, and you guys hit the nail on the head, having if surgery's in the picture, having the definitive person doing the resection is helpful to be there, because it happens where somebody's on call and say, because we do trachs all the time for airway security. We put a trach in, we secure the airway, and then we kind of figure out the game plan later on, especially in this area when it's this high up. Sometimes people who are not used to doing these resections don't understand maybe a good placement for the trach to preserve healthy airway, or sometimes they'll trach right through the cancer, which now you're seeding extra cancer. So I think it is very important who you're considering doing that as well for more definitive management down the line.
All are good points. We're going to go south a little bit. We're going to go from upper trachea and go down a few centimeters to the mid trachea. So this is where Britney would be really extending her services and called, and I'm sure you would act upon it if absolutely need to, and coming into more share of a territory between Erin and her colleagues and myself and my colleagues. So we're in the mid trachea. Erin, what do you want to tell us about the mid trachea?
Oh my God, I love the mid-trachea. The mid-trachea is a great space. And honestly, it's a space that we end up spending a lot of time, and it's a space that Britney and I spend a lot of time together. And so, for any thoracic surgeon that's, out in practice alone, or maybe doesn't do a lot of these, like, phone a friend, call your, local neighborhood friendly, ENT surgeon. They'll come help you. And between the two of you, it makes it a really, really fun surgery, makes it brilliant surgery. But when I think about the mid portion of the trachea, the lovely thing about the trachea is you can take out a huge amount of trachea and still put it back together again. But some of the tenets that I think are really important is, one, know the true extent of the disease you're removing. Make sure you have your margins above and below. Make sure you truly, truly understand that extent. And it can be very sneaky. And so doing the scope yourself is really critical for planning that resection and repeating it the day of. Obviously all of the handling of the airway, making sure you have the right tools in the room to get past any area of obstruction is really critical. And then at the time of surgery, obviously getting your trachea beautifully exposed, minimizing that dissection along the lateral border, so you're preserving your vascular supply. It's very important. The trachea is not a super well vascularized organ, as we all know. And so really preserving that and limiting your dissection as much as possible. Always thinking about your recurrent laryngals. Those should be in your head. They should be haunting you in your dreams to make sure that you are preserving them, keeping them safe at all times. And then really leveraging the mid-trachea is actually a very great area to be able to reach from the neck. I do a lot of these through a cervical incision. You extend the neck back, pulls the trachea up a huge amount, make liberal use of mediastinoscope to really free up my anterior trachea, my main stems, to be able to pull things up. And at the end of the surgery, bringing that neck back down, sometimes using the Grillo stitch. Yes, we do have naughty patients sometimes who earn themselves the Grillo stitch, or just using a nice neck pillow to keep the patients comfortable after surgery. It's a great procedure. I really enjoy doing them, and especially when Britney gets to come hang out with me.
So, Britney, let's say this patient with this mid-tracheal obstruction ends up in your clinic. What's your threshold for urgent endoscopic relief versus going straight to surgery?
I would say, it's really just depending on their history and symptoms. So if this is somebody who's had multiple surgeries in the past, a lot of balloon dilations, things like that, we'll see that not infrequently for some of these, like not necessarily cancer patients, but subglottic stenosis patients or previous trach patients who've had just a bunch of scarring now and need some relief. I really look at their surgical history, their past medical history to see how long has this been a process? Have they been able to, live like this in between balloon dilations for a while, or is this something that they're immediately presenting they've had no intervention with before, and now you're kind of like starting from ground zero with them? So I think just looking at them clinically when they present, how bad off they are. If they're really struggling, you want to expedite them, and any way you can do that from a surgical standpoint, I would go for. Honestly, I would probably hand it more off to you guys though to see if there's something, interventional pulmonology stent wise or debulking balloon dilation would probably be more of my go-to, and see, what options they have from your guys' hands.
That's very interesting to hear. So next thing I want to talk about is let's talk surgical goals. So Erin, for everyone listening, and next I'm going to hand it to Britney, 1 to 3 surgical goals for all patients that you're seeing with this kind of mid-tracheal disease. What do you got for us?
Yeah. So I think, one of the things that we haven't dove too far into yet is pathology. Like, what is causing it, right? And so there's a lot of different tumors that can arise in the trachea, since we're sort of mostly focusing on malignant. The 3 that I see probably most commonly are going to be your adenoid cystic, which we know tend to be really lazy. They tend not to have a huge amount of submucosal extension. And so for that, if we have a patient who can tolerate surgery is sort of going to be the gold standard of that. We do have radiation in our back pocket as well. And so getting, really a nice surgical resection, negative margins for that, bringing the trachea back together under no tension with, nice wide lumen, so we can have a patient with no postoperative obstructions, really, really critical. Mucoepidermoid, a little bit more variable, right? And so they come in sort of a lower grade, mid-grade, higher grade. Again, surgery tends to be the gold standard of that. These can be a little trickier, right? We know these tend to have a little bit more extension. They can be a little bit sneaky. Getting negative margins can be a little bit more challenging. I think one of the really key things here is you cannot over resect and not be able to put the airway back together. You just cannot end up in that circumstance. And so you have to go in with the mindset of, I'm going to get out the brunt of the disease. And this is where it's really critical to know your true extent and how much you can safely take out. And by golly, if you've taken out the majority and you're not at a negative margin and you're at the limits of what you can resect, you have to stop and use additional therapies. Obviously, squames are another big one that we see, as a primary as well. Those, it's really critical to understand, is it single site disease or is it a little bit more extensive? Sometimes we can do really creative things like use local therapies combined with resection to get rid of bigger burdens of disease or sort of wider lengths of disease, which is fantastic. And then, of course, an occasional carcinoid. Now, I usually see those more distally. They're usually in the main stems, but every once in a while you end up one in the main trachea. Again, surgery is a great option for that. But again, sort of margin negative, not causing any harm, getting the airway back together, not damaging surrounding structures, right? So making sure those recurrent laryngeals are safe, doing your anastomosis in a way that you're not going to get stenosis. So using those beautiful absorbable sutures. My bias, the way that I do it, I tend to do a running posterior and then either a running separate anterior or interrupted, depending on the exact size fit. So making sure you get that really nice wide open lumen, and then getting your patient well recovered.
I'm going to excuse everyone from explaining my suturing skills, since we have you two in this room here. Those are very important and great points, Erin. Britney, anything you want to add?
No, I agree. I agree with the pathology assessment. I mean, those are right on the money on what you're kind of expecting in this territory. And it's a hard as a surgeon going in there and being like, I know, if you're having positive margins and I can't resect anymore, but you really do have, you cannot find yourself in that situation that you're just going to take a little bit more, and then you can't put it back together. I think, from a pathology standpoint, at that point, you're looking at other adjuvant treatments besides surgery. And, your goal is to get the airway open, stable enough for the patient to kind of proceed on to those next therapies.
Excellent to hear. So we're going to go a bit more south and approach the carina. So I would say here that the stakes rise, because complications here can affect both lungs, and you can have disastrous complications because now you're approaching some vital structures near the mediastinum, et cetera. Brittany, how far down are you staying involved here before you say, nope, not me?
I will never say nope, not me. I'm always there to help, but I'm definitely going to say nope, not just me. This is where I definitely would have some other colleagues, thoracic surgery, particularly in my realm. I'm always there to help. If it's down this low, is there anything I can do up high to release anything? Things like that. Can I open, release fascia, things like that? But honestly, not a lot from my standpoint on from a surgical aspect for how much I'd be helpful doing some of that down low. I think Erin comes into play with some of those lower release things and kind of techniques. So I'm there to help as a helpful friend. That's a good up high, but I would definitely ask for help on the lower end of things.
Erin, as a thoracic surgeon, you have to catch this hot potato. So what are your thoughts on disease near the carina?
Yeah, absolutely. So you're right. The implications are, significant when you're thinking about carinal involvement. And in a lot of cases, it is, certainly you have just carina and just, distal airway to where you're thinking about kind of plugging both main stems back in and bringing them back into the trachea. Yes. That's a pretty rare circumstance. I say more often I'm seeing, a big portion of a main stem involved all the way up to the carina, lower airway. And so I'm thinking about doing a carinal pneumonectomy. So we're losing, one whole lung and we're losing part of the main airway as well. And then bringing back in as a sleeve resection, really the opposite lung. And so really, hearkening back to some of the comments made earlier about making sure the functional status of the patient is going to meet the ability to tolerate this level of resection is significant, right? So now we're talking about a transthoracic approach, single lung ventilation, potentially losing an entire lung with a big reconstruction. So making sure that patient has excellent nutrition because we need them to be able to heal, from a surgical standpoint, making sure that we're leaving our margins dirty, and that's not dirty from a tumor standpoint. It's that we are leaving a lot of tissue around where we are going to be plugging things back in. So we're maintaining that beautiful vascular supply. Obviously, cardiac fitness, pulmonary fitness can tolerate, loss of whatever part of the airway it is. And then really making sure postoperatively that we're doing a lot of walking, pulmonary toileting, all the things that we need to help make sure they recover really meaningfully. It is great to have a friend who can do a high rate release if you need to bring things down to you. Obviously, we can do our inferior releases as well. So really, freeing up the entire mediastinal pleura, and then obviously doing our infrahilar release in the pericardium, that can move that lung up beautifully to be able to plug a main stem back into the trachea.
Good to hear about all the surgical options. So from our perspective, carina, main stem, that's really where we live and see a lot of this disease. And for us, sometimes we are the first to see these folks because they come in for hemoptysis, respiratory failure, and just based on the extent, location, and suspected involved lymph nodes on CT imaging that's already been done, they very well may not be good surgical candidates. And we're looking at some sort of bronchoscopy to do for both diagnosis, therapeutics, and staging information if we don't already have it. And really it comes down to debulking, whichever way I can do it, rigid bronchoscope, cryoprobe, any sorts of heat ablative modalities, et cetera. If the airway is not reestablished, stenting. And then the next question is neoadjuvant therapy plus minus resection if we don't have all the information that we need already. As I mentioned before, it's a high risk area just because it's near some things that we never want to poke into. And the significant risk of bleeding into both lungs can be just devastating if that happens.
Absolutely. And I'm going to be honest with you, having done a lot of these cases with my friends like you, Samir, at Creighton, and Zach DePew and Kush Ratwani, like these are cases sometimes they're calling me too as well and saying, hey, let's look at this all together and figure out a strategy. And it is, sometimes palliative, sometimes it's to buy time for the neoadjuvant or buy time for a workup to figure out if a patient will tolerate a more complex resection. And it's not easy, right? The stents that you guys have are fairly limited in configuration, where you might have a really big lumen up top, a tiny one down at the bottom. The stent is being pushed up. Patients are coughing a lot, which can displace. Talk to me a little bit about some of the things that you do to try to help manage a stent, both for palliative, to buy time, for surgery. When you're thinking about having a stent in the airway, how are you managing that after the procedure once you get it seated in that perfect location?
Yeah, that's a great question. So the first thing I ask myself is, when is the stent coming out? As soon as I place it, when's it's coming out? And the timelines are different. For benign disease, completely different conversation. They stay in a little bit longer. But for malignant disease, the stent is just temporizing. It's opening up the airway for what else can be done next. So this is where I have very close coordination with whoever else is involved, whether that's medical oncology, radiation oncology, surgical colleagues, et cetera, about what's the next step here. And sometimes, and a lot of times, the next step is chemo, immuno, plus minus radiation therapy. The other thing I really harp in on is, what can I do to give the patient the best shot to keep the stent open? So some sort of stent management regimen is good. There's a few studies out there saying some things are more effective than doing nothing. My typical go-to is hypertonic saline nebulizations and twice daily guaifenesin. As long as that stent's in place, that really helps keep those secretions moist and they can cough it up. And then very, very close coordination with the oncologist, whether that's med or radiation, and surgical colleagues, about what the next steps are. The best stent is no stent. The second best stent is one that can come out intentionally the quickest.
I love that. Brittany, talk to me about some of your airway tips and tricks, because, not only are you helping people who have stents in place sometimes, but also ongoing airway obstructions, trachs, things like that. What are some of your go-to tools for helping to manage patients, outpatient, maintain high quality of life, and manage the secretions, which can be really challenging?
Yeah, secretions are hard. From an airway standpoint, we always talk about the most common things we probably hit on the most is basically like any drainage they're getting up high or reflux that's coming down low. Anything that's, because when we're working in those areas kind of conjoin all at one. And when people get swelling, they get kind of this like irritation there. They really get bothered by it. And so anything you can help to eliminate those things are helpful for them. So I'll use like some like Atrovent drying drops from a nasal drainage down up high, down low, and then I put them on, acid reflux medication. I'll do a regimen for that. Either if they've seen GI, I'll keep them on them, or I'll reach out to their GI, or I'll start them on my own. And those are kind of my big things, is anything that I can help from that standpoint to help them just get comfort and also not that irritation.
Mm-hmm.
Love that. You guys, it's funny that we talk about all these things. We all do very similar things in practice, coming from very, very different backgrounds, because they work. And everything you guys have talked about are like the mainstay of my postoperative regimens for anybody who's had anything airway, right? Whether it is a tracheal resection, a carinal pneumonectomy, a sleeve resection, which we do more and more commonly after neoadjuvant for complex, proximal tumors. Everybody is getting, the respiratory regimens, Mucinex, use those lungs as much as possible. Everyone goes home with, incentive spirometers, aerobicas, acapellas, whatever, sort of your hospital version is. And then just importantly, reminding patients, like, stay as hydrated as you can, which helps to thin out those secretions a little bit too. And walk and move your lungs. It just helps.
Yeah.
Okay, switching gears one last time before we sort of wrap things up. Let's talk a little bit about communication, because I feel like that has been a common thread that we have talked about throughout our conversation today. And multidisciplinary tumor boards are a critical part of that. But one of the things we have said over and over again is, I call a friend, I make sure that they're, we see these patients together. How are you guys actually doing that in practice on a day-to-day basis so that it works seamlessly? Because we have busy jobs. We're all in different places. We're in procedures. We're in clinics. How are you guys making communication work as effectively and perfectly as possible? Brittany, I'm going to toss to you first, and then Samir.
This is like so key with these. As you can see, you have three of us who are three completely different fields, but we all have to work together in this, complex way. And you cannot work with other physicians, other surgeons without communicating. You have to, as a physician, as a surgeon, you have to be a good communicator, because these patients are so complex and they're in different clinics, they're at different days, at different times, and you have to find an OR date to do their bronch together. I think just being open on the communication. Joint clinics are great. It's very hard to run, because this, from my standpoint and your standpoint, this isn't all we do. I see everything from, skin cancer to airway to thyroid. So you get a majority of a wide range of clinic things. So they're not just your only clinic patient. So running just a joint clinic when you only have 1 or 2 clinic days a week is pretty difficult. I think tumor boards are excellent. I mean, we go to weekly tumor boards for everything: skin, airway, thoracic, esophageal. At this point, there's tumor boards for everything, which is great because they are so complex. So I think my big thing is having a group discussion with everybody involved who's going to be involved from these patients, and then just working as a team and being open that, hey, sometimes your schedule is not going to be the priority, but the patient is, and then you kind of work to make it work for you. And I feel like you can do, there are ways you get it done,
Yeah. And frequent phone calls, right? Like, I mean, how often do you guys, when we talk to each other on our way home from work, I'm like, hey, did you see so-and-so today? Me too. What are we going to do?
We're just driving past each other in the car being like, oh, hey, by the way. Yeah. I just think being open to communicating and knowing when to ask for help and when you say, hey, I need help. Like, this is a complex patient. We need to do this. We need to do this soon. And not like, hey, this is going to be a message. This patient. It's just picking up the phone and, really emphasizing what's going on and, finding great colleagues to work with.
I love it. I love it. Samir, how are things working at your place?
Yeah, I've heard great things about joint clinics. We don't have one. I heard they can be incredibly effective, but logistically, as Brittany was saying, they're tough to pull off, right? So for us, most of the planning occurs during our weekly thoracic tumor board. We also have a monthly major airway disease conference in which our ENT colleagues also hop on, where we can talk through some cases and things like that. There's also real-time coordination too. So all of our bronchoscopies, including our rigids, are done in our endoscopy suite. And we're fortunate enough to have one of our laryngoscopists who also does some of our procedures there, who can always pop in, take a look, and opine on something if we need a set of eyes on it. It's very easy enough for us to coordinate cases in the OR with our thoracic surgeons and our ENT surgeons as well. So there's a lot of built-in collaboration, even though it's not a joint formal clinic.
I love that. You guys, saving patients together, what a gift, right? How cool are our jobs? It's amazing. All right, you guys, amazing discussion. Let's talk some key takeaways. Samir, kick us off.
Yeah. So my takeaway, teamwork is not a buzzword here. It's the whole game. You need to communicate early, plan together. You got to stay flexible. If you do those things, the patients are going to win every single time.
I love that. What about you, Brittany? What do you want people to take home from today?
I'm going to reemphasize the teamwork thing for sure. I mean, that's priority here, but also planning. Prep and planning is important. It's having the right imaging. It's having the right plan. I mean, these are complex cases that you need to have anesthesia on board if surgery is being involved. Every surgeon needs to be on the same page. The patient needs to know what they're getting in for and what the risks and benefits are. So I think teamwork, one, but also just the prep and planning is almost the hardest, harder part than surgery sometimes, and getting the right setup to make a successful outcome.
Absolutely. I love that. That's such a great message. And honestly, this is one of those situations. It's measure twice or 5 times, cut once.
Pictures.
Measurements, to make sure that you nail it every time. And then how cool is it to get to celebrate the cancer-free anniversaries, the stridor-free days at home, and the patients who are really thriving in the post-op? That's the greatest gift of all.
Absolutely. Brittany, I can't thank you enough for joining us today and truly just elevating our conversation. To our audience, stay tuned. Our AABIP and STS collaboration will continue with an upcoming episode on pleural space infections, followed by our favorite topic, ECAC. No, I'm just joking. We will talk about ECAC. I'm not sure if it's our favorite topic, though. Stay tuned. More to come.
Wishing all of our incredible listeners a wonderful rest of the day. Thank you for joining us. Please continue all of the incredible and inspiring work that you do. Please keep educating people about lung cancer and the importance of screening. We are all super passionate about making sure that we can prevent as much cancer as possible. Keep taking extraordinary care of patients. And as always, keep smiling. Bye, guys.
To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.